Hello everyone, this is Group 12 on Applied Medical Anthropology. Objective. In both Rojas and Lane, the authors emphasize that applied medical anthropology is rooted in collaborative partnerships. These partnerships aren't symbolic, they shape research design, intervention strategies, and long-term sustainabilities. The Rojas articles specifically highlights how these knowledge Hello everyone, this is Group 12 on Applied Medical Anthropology. Objectives. In both Otorolo, Rojas, and Lane, the authors emphasize that applied medical anthropology is rooted in collaborative partnerships. These partnerships aren't symbolic, they shape research design, intervention strategies, and long-term sustainability. The Rojas article specifically highlights how this knowledge is preserved through intergenerational teaching systems and how healers' authority is embedded in spiritual and ecological relationships with their land. The Lane article demonstrates how anthropologists embedded themselves directly in clinic routines, shadowing providers, observing patient flow, conducting interviews, and participating in staff meetings. These methods allow us to see that applied anthropology isn't just about recording culture, it's about using cultural understanding to directly improve health outcomes and systems. What is applied medical anthropology? Rojas describes this work as a participatory conservation approach, meaning that communities co-produce knowledge and strategies rather than serving as a research subjects. The authors stress that Kichi worldview understands illness within a relational system involving spirits, ancestors, and the forest. Applied anthropology must therefore respect these frameworks, not override them. In Lane, the authors reference the idea of structural vulnerability, showing how patients' health is shaped by precarious work, immigration status, transportation systems, and barriers. Both articles exemplify the applied anthropological goal to understand health holistically, including cultural meaning, political structures, and ecological conditions. Why does this matter? Rojas emphasizes that erosion of forest land directly reduces availability of medical plants, and that healers see ecological decline as part of a wider moral imbalance. The authors also highlight that Kichi healers are often excluded from mainstream health initiatives despite their influential community role. In Lane, the clinic documented how patients frequently skipped appointments due to unpredictable work schedules, childcare issues, and competing basic needs. The article notes that many patients express discomfort or distrust towards large hospitals, preferring the free clinic because it felt more respectful and safe. Both readings argue that health systems must work with cultural and structural realities, not against them. The article outlines how Kichi healing practices rely on availability of specific plants, many of which grow only in protected forests. The authors collaborated with the community through the Maya healers, This served as a cultural authority and partner in designing the project. One of the project's main goals was to address healer concerns that youth were losing interest in traditional medicine due to migration, wage labor, and Western schooling. By strengthening healer apprentice networks and establishing medical plant gardens, the project directly supported cultural transmission. Key insights of the Rojas article include Kichi health specialists categorize illness as natural, supernatural, or social, and healing may involve prayer, ritual cleansing, or plant remedies. The researchers documented over 100 medical plants and their uses, pointing out that many have been validated by biomedical studies. The Medical Garden Initiative created community managed plots so that healers could cultivate plants that were disappeared from the wild. The program also included school-based environmental education, linking youth to healing traditions and conservation practices. The authors show how conservation and health are inseparable in Kichi's worldview, leading to dual environmental and public health benefits. Carrying on to the Lane article, the author describes the clinic as functional with limited staff, volunteer physicians, and overcrowded waiting rooms, conditions shaped by the U.S. healthcare system gaps. But anthropologists use participant observations to map out patient journeys, identifying where delays, confusion, and miscommunication occurred. The article explains that many patients were working poor immigrants, or individuals with chronic diseases who often went years without consistent care. The authors also note that trust building was essential. Patients were more forthcoming and reliable when staff spoke their language or shared cultural background. Findings and text-based details. One crucial insight that anthropologists found was that follow-up failures were structural, not personal. Patients often lacked phones, stable addresses, or consistent work schedules. The clinic's paper-based system made it easy for files to be misplaced, leading to delays that discouraged patients from returning. The team helped implement systems such as multilingual signage, transportation resources, and redesigned flowcharts to streamline patient navigation. The article explains that anthropologists also facilitated communication between volunteers and staff, identifying how differing assumptions led to operational breakdowns. The authors conclude that addressing these issues required ongoing involvement because structural barriers removal is never a one-time fix. Comparing both cases. In Rojas, the focus is on ecological and cultural sustainability, how the health of forests and the health of people are deeply interconnected. In Lane, the focus is on structural vulnerability caused by social, economic inequality and failures of the U.S. health system. Both demonstrate that health interventions require embedded relationships. Apprenticeships and healer alliance in Belize, and patient-staff collaboration in the free clinic. In both cases, researchers acknowledge their positionality and work to ensure community members define their own priorities. To conclude, the Belize project demonstrates that applied anthropology can preserve both cultural heritage and biodiversity, influencing future conservation policy. The free clinic study shows how small incremental changes like adjusting intake process or improving communication can meaningfully improve patient outcomes. The authors of both studies stress that respectful engagement, long term collaboration, and humility are essential for meaningful change. Applied anthropology reviews that solutions must emerge from communities themselves, not be imported from outside experts. Now, on to discussion questions.